This video made possible by Killer Visual Strategies. Visit killervisualstrategies.com.
Tech track. I'm a reporter with GeekWire. I cover health technology. I've interviewed a couple of you already. And so today, as you mentioned, we're going to be talking about how telemedicine and digital health are driving more consumerization in healthcare. I think it's a topic that resonates with a lot of us. It's something I'm personally very excited about. I want to be using my cell phone to do everything healthcare related. Currently, I can use it to do nothing healthcare related. So we have a great panel lined up for this discussion. So first we have Nirav Shah, CEO of Sentinel Health. Nirav is a neurologist and the former stroke doctor at Swedish Hospital in Seattle. His company Sentinel makes a platform that uses the Internet of Things to remotely monitor and suggest treatments for patients with high blood pressure. We also have Shyam Gollakota, who is Associate Professor of Computer Science and Engineering at the University of Washington. Shyam has been doing some really remarkable things with smartphones and smart speakers over at the UW. And he and his students have made apps to check for ear infections and to monitor people for opioid overdoses and for heart attacks. And lastly, we have Amanda Cuda, who is joining us from 98.6, where she's the medical director. 98.6 operates a telemedicine platform that uses artificial intelligence to save money and improve care, all while making physicians' lives easier. And they recently announced a program that brings their platform to Sam's Club members, a really big new pilot program there, and they're also working with, I believe, University of Arizona, so expanding pretty rapidly here out of downtown Seattle. And so thanks to you all for joining us today.
Thanks for having us.
Thanks.
And I also want to mention we're going to have a bunch of time at the end for questions from the audience, so think about what you might want to be asking these folks as we go along. Let's get started. So in some ways, what we're talking about today is how healthcare is catching up to the world of consumer technology. And with that in mind, if you take one product or even just a feature from the consumer tech world and just throw it into healthcare today, what would that be?
I guess I'll start. So for me, I think the one thing that I love the most about kind of the world we're in now is this on-demand type of experience, that with Uber and Lyft and just being able to press a button and all of a sudden the car shows up. And so to me, it's this on-demand, this ability to just press a couple buttons, open an app, and then have a healthcare experience.
I think it's basically the neural networks, which are the basis for a lot of the facial recognition algorithms, which are used by Facebook and Google. The same underlying technology can have a significant impact in the mobile and the healthcare domain. For example, for figuring out if you have tumors in your CT scan and automatically figuring out what these images are. One example of a project which we are doing in our lab is in the context of recognizing birthmarks. If you're a parent, you realize that if you have a birthmark on your kid, you don't know if it's actually benign. Does it require any kind of a treatment plan, or does it require a surgery? And it turns out that there are about 9 to 15 different kinds of birthmarks, which are called vascular anomalies. And each of these require a different kind of a treatment plan. And even it's hard even for a pediatrician to look at these birthmarks and figure out if it's actually something which requires treatment. You need to go to an expert, a vascular anomaly expert, to basically do this. So basically, by using the same neural network algorithms, which are basically used by Google, we can train an algorithm and classify all these neural vascular anomalies, and we can get accuracies which are actually comparable to what an expert can, a vascular anomaly expert can actually get. And this is pretty impactful if you think about it, because basically, if you are living somewhere in Alaska or in Western Washington where you might not have access to a vascular anomaly expert, all the pediatrician has to do is take their phone out, take a picture of the birthmark or vascular anomaly, and you automatically know what kind of a vascular anomaly it is and what kind of a treatment it would potentially require.
Well, James, I would start off with getting you up to date on the consumerization and get you our app from 98.6 on your phone, because you need a platform to actually deliver care, in my opinion. So I feel like what we offer is that type of a platform. If we were to do something in addition to that, I would actually love some tool that would achieve interoperability. So it's been mentioned a few times today already, but I think I'm a family physician. One of the biggest struggles that I've had in every system that I've ever practiced in is the ability to communicate between systems around a patient's care.
So you mentioned the on-demand nature of telemedicine and remote monitoring. You know, those both really make it possible for us to intervene, or not us, but for physicians to intervene with their patients. You know, the second something goes wrong, it gives the patient the ability to contact their doctor. It gives their doctor the ability to monitor them and make sure, okay, is everything going well? So, you know, it may seem obvious, but why is that such a big deal?
Well, so access is by far the biggest problem in healthcare. I mean, 98.6 clearly is the big step forward in solving that. And Sentinel's take is to provide the remote monitoring infrastructure so that it's not just getting access to care, which telemedicine, video-based or chat-based might be able to do, but it's also giving you meaningful data so that you know where people's trends are from a longitudinal perspective. So our first use case is just blood pressure, because it's such a common problem: high blood pressure, low blood pressure. People who've had a heart attack, who have blood pressure problems, account for easily the biggest amount of healthcare spend. Hypertension kills more people than all cancers combined. And part of that, the dilemma in managing this problem is that, you know, if I see someone with a stroke, for example, at Swedish or any one of the great Seattle area hospitals, wait times to primary care were 90 days for me and for others. If you're trying to get Parkinson's care in the state of Washington, it takes you 88 days at least on average to get into a clinic, and that's after you've had a referral from primary care. So even within the system, getting in the first pass, getting to that primary care doc and getting that referral, usually insurances require this sort of PPO referral from your primary doc to get you to the next person, is incredibly long, and there's a lot of burden just being built up in that wait time. And so to me, that's why the on-demand is really important. And then going beyond that is, you know, to Amanda's point, is switching that to sort of engaging and predicting and then making it passive, so that you're already part of the platform, you're already being monitored such that now we know your blood pressure has changed drastically relative to, let's say, your prescriptions, so that we can then use cloud anomaly kind of detection systems, machine learning, all the modern advances we're seeing to make real-time interventions.
Yeah, I'd love to. I mean, access and on-demand is what we're about. So, like you said, it's the dilemma of our system, as you mentioned, and I do think that there are a lot of barriers to access to care, and time is a huge one, and just the transportation can end up being one. So our culture and the way of our lives really has led us to a point where everything we want is sort of on demand. So it is a little bit of this alignment with just kind of what our culture is becoming, and there's obviously trade-offs with that we know about, and kind of the technology discussion. But in terms of medicine, I think access is really the first, the key issue. And whether you're talking about access of, just having it right in front of you, kind of on-demand sort of situation, or having enough, physicians or primary care providers to also be able to, feed into a system, and there's all sorts of interactions there.
So thinking about like the kind of the things that stand in the way of us getting to this immediate access, what should health companies be doing to gain access to that immediacy, to remove some of the barriers that stand in the way currently?
Well, I mean, I think the biggest problem is just labor, right? So, I mean, thinking about how to give power back to the patient, creating some, something that's on demand, that's accessible and continuous, and maybe even passive, should we, aspire to go beyond these first steps, is really there's not enough labor in the healthcare force. And so at least our take has been video-based care was widely adopted by stroke neurologists, which is my background, in the late 2010 kind of region and early part of the decade. And so, at Swedish, when I was a medical director there of stroke, I covered 15 hospitals all the way from Alaska throughout this state. Sometimes we transfer people from Montana, Oregon, although more rare, for very aggressive and acute and highly specialized things. And while that's great, you still need one neurologist to be able to be on call 24/7, 365, to just administer, triage, and manage where these patients come from. And so that's great. That provides a little bit of scale, but from a primary care perspective, it doesn't solve the problem at all. And so what I was seeing in my clinic as a stroke neurologist is that even after I'd done all of that work, someone would come to the hospital, go home. We had a 58% go-home discharge rate here in Seattle. That's consistent with the state. And then they'd come back, and then yet they had high blood pressure, right? And so to me, it was just this big disconnect between we put all these resources, fly people in, and then we're not able to get them the care that they need. And so I think it's figuring out how to scale healthcare labor that doesn't juxtapose with burnout, which we both talked about before, And how do we make it so that we're not just doing more to take care of more patients? Because there are going to be more patients. There's no doubt about that. I mean, people use different kind of rhetoric for this. Increasingly, the silver tsunami is the term. But at some point, that's a good term, I think, because it just feels like it's getting worse every year. And hospital wait times are getting longer. It's clear the hospital-based approach just won't work, which has been like the American healthcare's main way of dealing with emergency. And preventative care should work. It's working in other places that are more homogeneous, that have smaller populations, that are easier to control, easier to train. But I think in our case, we're going to just need massive amounts of infrastructure. We think that's remote monitoring. That's part of why I took the jump, left my job, and this is all I do. This is all I do.
Yeah, so when we think about remote monitoring, like one way to do it is to create a new device that will monitor you remotely. But we also have these devices on us all the time that are increasingly being used by 98.6 through their app. And Shyam, you were doing some to me, absolutely insane things. Using our cell phones for purposes that probably the inventors never even imagined. I look at my phone as something just to kind of gain access to information, to communicate with people. I'm wondering, how do you see the role of the smartphone going forward in medicine?
So I think of smartphones as a way to democratize medical devices. If you look at, for example, a common problem of ear infections, you need to go to the hospital. You need to basically, that's one of the main reasons why parents take their children to the hospital. And to diagnose it, you need to go and get a tympanometry or a pneumatic otoscopy get done. And these devices are pretty expensive, $2,000 to $10,000, not to mention the time. The parent actually has to take time off and take the kid to the hospital. So the question really is, can we repurpose the smartphones, which almost everyone has, and do something which can diagnose an ear infection? So here is something which we actually created recently. So this is basically just a smartphone, an iPhone. And all you have to do is have a paper funnel, which is attached to the smartphone. And this can basically diagnose your ear infection. But basically, that's it. And the way it works is that you have a microphone and a speaker which every smartphone has. All this device does is it transmits a chirp from the speaker of the speaker on the phone, and you just put it in your ear, and you get the reflection from the eardrum, and you can analyze it using machine learning and figure out if you actually have an ear infection. And this is pretty significant because now you can start repurposing your mobile phones, which almost everyone has, and you can basically enable remote monitoring.
And even beyond smartphones, I mean, you've done work with smart speakers. I mean, we have, growing use of smart home devices. What are some of the other devices that make you most excited about, their potential for application?
I actually think that smartphones is the next big thing in the healthcare for enabling remote monitoring of health. For two main reasons. Unlike a mobile phone, which you need to keep recharging and you require the person to keep turning on an app and have the person do the action of opening the app, a smart speaker, which is basically powered and put next to your bedside, can basically monitor you all the time. And that's pretty significant because you don't need to it's kind of invisible. It becomes invisible. You don't have to really go and do an action of going and turning on a device to track your medical vital signs, for example. So one example project which we did was in trying to figure out if someone has a cardiac arrest. And the way we did this is by basically using a Alexa Echo. So we have an Alexa Echo, and it can basically listen to sounds which happen when you have a cardiac arrest. And one of these sounds is an agonal breathing sound, which is basically gasping of breath, which happens a lot when you actually have a cardiac arrest. So what we showed is that by listening to these sounds, we can, with a very high accuracy, detect when someone is having a cardiac arrest and automatically call 911, which can be done by your smart speaker, which is listening all the time in a very passive way. And that's pretty incredible because now you can basically, there are more than 200 million, there are around 200 million smart speakers in the United States. And that basically means that each of these devices can be used as a medical device, which is which can save a lot of people's lives.
So thinking about kind of the software side of things, we have the hardware, that's great, but we look at most of our apps, and apps are designed by and large to get us to use them as much as humanly possible. We have all of these features that make them addictive, and that can be really problematic for a consumer app, but in healthcare we know that more engaged patients generally have better outcomes. So what are you borrowing when you create a health app for patients from the consumer tech world, and sort of how are you getting patients to actually want to engage with these new technologies?
Well, I think it's UI UX, right? I mean, so like all of us have used probably Bluetooth headphones or Bluetooth in some capacity with our car. And it's a pretty poor user experience because it takes all these steps. You have to go to settings and pair, and then maybe it works, and then maybe it doesn't the next time you use it. But then at least when I got AirPods, you just turn it on, you put them in, and they automatically sync. And it's just a great user experience. And I don't know about you, but I'm kind of addicted to these AirPods. I think they're going to be a big part of how we deliver health and think about health and computing on the edge. But for me, that's really exciting because now just reducing one step or two maybe, a couple of taps, clicks, has all of a sudden made me want to use this more, and it's just much more functional. And so I think that's the era we're in. It's just UI, UX. It's all about user experiences and the interfaces, because if it's easier to use, you'll just use it more. And so we found this, I mean, just for our app, we spent an incredible amount of time, the better part of a year, just making the Bluetooth connection between devices that we connect to and a patient's phone work really, really well. And it's still hard because there's some limitations in Bluetooth. And so, our average age person is 72. We take care of people in the Medicare Plus demographic. It's how we sort of get reimbursed. And so we're taking on, a couple unusual things. We're trying to do this in healthcare, and then we're also doing it in people who are already sick and elderly, who typically who've had a heart attack and stroke. And then on top of that, we're trying to give them an app, which this demographic isn't always familiar with. And so it's got to be really, really usable, really, really friendly. And there's still lots of work to do in terms of how we are going to get there. But that's really what we think about all the time is, every time I look at an app, I'm like, wow, that's way better than ours. We're going to do that.
I think patient engagement is something that we all are trying to figure out the best way to achieve. And it's certainly very complex because on one hand, you want a patient to be engaged and to access care. I want a patient to come and utilize my app. But at what point does it become dependent, for example, and we're losing some of the patient's self-efficacy and being able to, make their own decisions about their health. And, so there's an element of, and what we have tried to do, and hypertension is actually a great example, like what Nirav was sharing. We can coach patients. And I think we've seen in a lot of the health coaching space that patient engagement increases as we give folks tools to, engage themselves in their care. And if I represent, or the app represents a way for them to kind of be reminded of that, then that's even better. Some of these, remote monitoring situations, amazing for folks with diabetes, for example, and you have continuous glucose monitoring, hypertension, catching, hypertensive emergency before it becomes that. And being able to maybe send a notification around that, through your app. Again, I think the smartphone is sort of going to be the hub of all of this. But I think there's different layers of the patient engagement.
Well, I think to what she was saying, just to jump in, is that, for us, because we have this elderly group and because we initially started kind of thinking about this from a stroke care perspective after someone's had a stroke, we decided we had to engage kind of caregivers. And so in our app, it's sort of borrowing like this notion from social networks, although it's a really small one, where we enable the family members. There's a lot of legalese that has to go behind this, from like release of information and HIPAA compliance, but we enable family members to kind of monitor the information of their loved ones. And so part of what we've developed is, dynamic alerts that go to the family members so that you know about your mom or your daughter or your son, et cetera. And because I've seen both. I've had 6-year-olds who are taking care of a 90-year-old mom, and I've had a 6-year-old taking care of a 30-year-old son who'd had a stroke in the setting of cocaine use and methamphetamine use. And so we just need to create kind of the same infrastructure that we've seen work so well from social networks, and just adapt them to this setting, because someone cares about these people. And across all major studies of people in ICUs who have suffered a significant event, one of the best prognoses for outcome is family. So having a good family that cares about you, that's engaged in your care, that shows up to appointments, is going to be one of the hallmarks of your success across your healthcare journey. And so we know that our people have that. It's just a matter of engaging those, and they may not be here. In Seattle, the patients may be on the coast, their family may be in Seattle. And so trying to figure out how to get everyone kind of using the same tools to connect together, which we already do. It's just putting it in the healthcare context.
I actually think that in the case of healthcare, the interfaces have to be invisible. You should minimize the amount of user engagement with the particular app. Very famous example is basically the Apple Watch. The first version of Apple Watch, when it was trying to track your heart rhythm, you had to put your finger on the Apple Watch, and only then it actually tracks your heart signals and so on. But the latest version, you don't need to really put anything. It basically continuously monitors your heart signal, and that's actually incredibly useful because you can then try to figure out if your heart is having irregular heartbeats, and the probability of you finding the irregular heartbeats is more if you're able to monitor the patient for a longer period of time. And the only way you can monitor the patient a longer period of time is if it's passive and does not require much engagement from the user. So I think in the healthcare space, the more you can get to passive monitoring and long-term monitoring, which minimizes the amount of engagement from the user, that can be pretty incredible. And I think that's the reason why smart speakers or earbuds are pretty good examples of devices where you can actually do these kind of a passive monitoring, where you just have a smart speaker by your bed and it basically tracks you and monitors you, gets your breathing, it gets all kinds of vital signs throughout your night, for example. Or your earbuds, which can basically get your blood pressure. It can get it's in your ear all the time when you're listening, so it can basically monitor you for longer periods of time without you requiring you to basically say, hey, can you please monitor me at this instance? And that, I think, should be the difference between consumer apps versus healthcare apps.
Yeah, and I think, I mean, what Shyam's talking about, in the literature, people are starting to call this ambient monitoring, right? Where it's not remote, where you're having to touch something, which is kind of painful. Using a blood pressure cuff is part of a relic that we inherited from sphygmometry, which it's not maybe even the best tool for monitoring for cardiac disease. Yeah, it's just the tool that we have. It's the FDA standard. It's very difficult to figure out how to get around it. But I think he's right. Like, we have to move to a world in which it's passive.
So thinking about these passive monitoring devices, obviously these are collecting lots more data than your physician would get during an annual visit. And on the patient side, you're giving up a lot of information to a third party. What do companies who are creating products in the space need to keep in mind in order to gain and keep the trust of the people who are handing over this kind of like all-consuming monitoring ability?
It's something I was even just thinking about in terms of, Dr. Dare was showing up all the movies that were sort of like the worst case scenario, and I always think about the Terminator, and like this space, like we have to be, aware of how much, choice and, involvement do I want to have, and, protecting privacy and all these other sorts of things like you're talking about when it comes to data and monitoring, and, is there going to be somebody who's going to monitor me at every moment and, everything that I'm doing and all of the thoughts that everybody has around that. And that's a real fear that patients have. And I think it's fair to, talk about that and consider that. So from our company's perspective, we just have multiple layers of security and privacy and lots of decision making that is really around the protection of data as, really a treasure. And because it's our patients. And, as the physician who's practicing, it's the same sort of thing in terms of, my safety in providing the care as well. So we really value that.
This, I think, is the most important problem in this space. One of the most predominant health or consumer health devices was the Fitbit. And this is a joke amongst physicians I talk to, which is that the patients used to come with their Fitbit data, and the doctors are like, what do we do with this? This is pointless. And I think there are multiple things going on over here. First is Fitbit made claims which are potentially not quantifiable. There was no proof that it's actually going to detect the things which it is doing. So I think in this specific space, it's really important to have evidence-based science, where you're making a claim and we're basically saying that something is actually doing what it's doing, you do have the science to basically prove it. You have done the clinical studies to basically prove that. I think that's actually very important. The second aspect is, what do you provide? What data do you provide to the physicians? Do you basically monitor their vital signs and just dump that data to the physicians? Or do you basically have some kind of ML algorithm or AI algorithm which is running, which can basically predict things, which can actually figure out what particular patterns are predictable? And this is actually a very complicated aspect as well, because let's say an ML algorithm is detecting that you have potentially, your tumor is basically cancerous. how is the ML algorithm figuring it out? How does a physician know how the ML algorithm is actually working? Because ML to a physician is basically a black box. So you need an explainable ML algorithm which can explain to a physician as to these are the reasons why you made this kind of a diagnosis. So I think there's lots of research to be done in the space, and you need to basically have computer scientists and physicians working together to basically come up with an ML and AI system which is explainable to the physicians at the same time which actually does work.
And I'm sorry,
Go
Nirav.
ahead.
I was going to say that is 100% accurate, and the amazing potential in that is that it gets to the supply and demand issue that Nirav was talking about. Is that we know that there's going to be the primary care shortage and specialty shortage, and if you can get physicians to the point of being able to sort of take on data through AI technology layering, then now I can take care of, I'm used to my 20 patients, 25 patients in a clinic day, but maybe it's, 50 or 100 even. And it seems insane. Like my, brick and mortar mind can't even comprehend that idea. How can that possibly be safe? But if you have these algorithms layered into it and we have the evidence behind it, then I can have confidence. Just like if I had a resident that I had a lot of confidence in coming and presenting to me a patient, I feel like I can trust them to then go and take care of that patient. And similarly, technology will help us with that.
Yeah, I mean, I think I agree. I mean, I think from a privacy perspective, it's interesting because we all hear about these breaches and HIPAA. It is quite cumbersome to navigate around. Although the P in HIPAA, at least one of them, is for portability. And so it was designed to make it easier to take information from one institute to another and transfer your data so that it could be used. And yet we're in this era 20 plus years after HIPAA was invented, and it feels like the opposite. And then the other notion is, and it's used, in systems, it's used as a reason not to do things. We can't do that because of HIPAA. You can't do this because of HIPAA, which is just really, really kind of cumbersome. There are definitely ways around it that can be creative, that are, well within the regulations. We find that patients really want to share their data, at least in the context that we're working in. And so I've never had a patient say, even when I was training as a resident, I would ask patients if I could record, for example, a seizure or some unusual movement that I hadn't seen before, because I needed to show it to the professor, the attending, the faculty, so that they could then kind of guide me on whether I was right or I was wrong, as opposed to me just describing to them. So we would often do this as residents, get forms filled. No one ever said no in that context, because they'd already gotten the trust. And so I think it's different being in a healthcare context than just being a big tech company. So for example, Apple has decided that they're not going to touch any data. They've gone to heroic measures to not send, for example, the EKGs that Shyam's talking about maybe analyzing to their own cloud. They don't have any of this information, which then gets to these, the distinctions between, let's say, Fitbit, which has published data on heart rates around the world, which is kind of fun to look at, but also kind of creepy in a sense. Because why do they need to know, what does that even mean? If people have fast heart rates in one country versus another, I don't even know what to do with that information. It's kind of interesting, but it seems strange, right? And so I think, we need to, as a society, figure out how do healthcare entities that are clearly responsible and signing up, and the patients know that they're signing up for healthcare, manage that data, as opposed to giving it to XYZ big tech company. And I think Apple's been really clear about how they're going to handle it, which is interesting, but then also means that, there's a whole set of things that they could potentially do that they won't do.
The other thing which people don't typically say is the tech companies are looking at how do you make physicians comfortable so that they adopt technology. But there also needs to be a change from the physicians. For example, what do physicians think of as data which belongs to the patient? If I have a CT scan, does that CT scan image belong to me or to the physician? Right now, if you get a CT scan, you're not going to get I got a CT scan recently for some reason, and I don't still see the CT scan. They just give me that, oh, there's no problem over here. That's only one line information which I actually got back from the physician. And the fact that it's my data and I don't get to see my CT scan is kind of incredible. The fact that why are we not all in arms about the fact that the healthcare system owns the data about us, which is our data. We need to be able to take our CT scan and get a second opinion or run an ML algorithm on the CT scan to figure out if I can confirm what the physician is saying. And that doesn't really exist today. And I can say as a computer scientist that should actually also be a change in terms of how the healthcare systems look at the patient's data and what they think of as, and I think that actually comes from the fact that physicians sometimes think that the patients are not capable of making reasonable decisions about their own data. And I think that's a really bad way of looking at patients. We're not, I mean, just because we're not a physician doesn't mean that we don't know how to be reasonable about how to interpret the data. And I think that should be the change which should happen within the healthcare system as well.
Well, and you're totally right. I mean, it's incredibly annoying that in this specific case, if I had a patient with a stroke, I couldn't just give them a CD. You'd have to leave the hospital, be discharged, come back, sign paperwork, and then maybe they would mail you a CD, and it would, they'd try and charge you for it until that was illegal. And so they'd try to charge you for the disc, right? And then eventually someone said, no, you can't do that. That's just not fair. And so you're right. I mean, it's really, really bad. And to your point, I think it's giving it to the patient is really meaningful as long as they have the tools somehow to understand it. And so, it's a delicate balance. I don't think there's a right answer on either side, because you don't want the WebMD version of this, and then you also don't want, right? And then some algorithm has some bug, and then it says you've got a tumor, and it turns out to be a meningioma that's totally benign, right? So it could be, there's problems on both sides. But I think from this broader perspective about how to kind of put this into the patient's hands, it's sort of educating them, and engaging them, giving them access, and then letting them make the decisions on their own. But to date, we haven't even been able to start those first few processes. So how do you get it off of the physician's plates into their hands? Because certainly the amount of data, that at least we're collecting at Sentinel, I'm sure the same for you, is just a ridiculous amount of data. I mean, we have hundreds and hundreds of thousands of vital signs that we've collected, and we're trying to structure around physicians, around their medications, and no one practice could do this. Part of why we're in 20 plus practices. We just signed with major academic centers as well. And part of the reason is because even though these institutions that have their own nurses and staff, they're just simply not ready to handle this amount of data. And that's what they're giving us permission to take care of for them. And so that's from the institution level to the patient level. We sit sort of in that bridge as patients leave their buildings. And it's still really, really hard, because our goal is to try to scale the healthcare. I mean, that's the only way that this will work, I think, is that if one nurse can sit, at least in Sentinel's perspective, in our office and take care of thousands of patients with high blood pressure, that'd be a remarkable achievement. And no one's done the hard work to demonstrate that that's even possible. And so we know that, for example, we can see maybe 25 patients in a busy primary care clinic, which would be stressful, and document at the end of the day and get burned out in 10 years. Maybe I can see 10 Alzheimer's patients that have long neurocognitive assessments. That's pretty hard. And actually get through the day and have the family conversation. So somewhere between 10 and 25 is like the limit. Anyone who says more than 25, I'm pretty skeptical of. And so doubling that, 10xing, that's really got to be the way we go. And while you organize, structure the data so that you can make decisions quickly. If you can't make the decision with the data, then what's the point of having it all? You're right, give it to the patient. Let them figure out what to do with it.
So we got time for one or two audience questions. Anybody want to? Do we have a mic runner, or can we get one?
I can talk real loud.
Yeah. Go.
So back to the conversation you were on. So right now we have the Office of the National Coordinator who is saying they have to release patient information to the patient. They're pushing very hard for it, but on the FDA side, they just released a draft on clinical decision support. And they said if the patient gets access to that, it's automatically a medical device. But if it's physician-facing, and to your point, you tell them how that algorithm works, and it's not a black box, then it's okay, and it's not a medical device under the FDA. I'm just curious what your thoughts are in terms of progress in this area when we're facing this kind of paternalism.
Yeah, so we met with the FDA a couple weeks ago because any time when one starts thinking about algorithms, how do you update an algorithm in the context that we're used to updating apps, updating software, and then how does the FDA regulate that? I still don't think they know, and they're very open about this. I don't think they think they know. They're not pretending to know, but one of the big dilemmas is, to date, software that's, let's say radiology focused in the AI context that has FDA approval, it goes through kind of sort of steady updates every now and then as the algorithm improves, but it's sort of locked down, which means we don't get the benefit of the addition of data until the FDA re-reviews it. It's very hard for them to figure out how to re-review it. In our case, the conversation we had is we're developing an algorithm that can predict blood pressure change. And so our first goal is if it's January, you start entering data in our kind of app and system, by February, can we tell whether you need a new medication or not? Up, down, is your blood pressure going up or is it going down too fast? Can we pull back or do we need to keep going? and the FDA is open to regulating this, but it's clear that they don't quite have a sense of how. And so I think that's why you're seeing these sort of, the ONC and the FDA and other people sort of all saying things that are really discrepant.
I actually have a very positive view of the FDA. We had a couple of meetings this year with the FDA for some pre-sub meetings, and the impression I got was that they were really trying to do what they think is the best for the patient and to try to find the evidence. And in the context of mobile health and computational health, they also release rules, which basically software as a medical device, where they say that you don't really need to regulate the underlying hardware. So you don't need to basically regulate the iPhone or your Samsung phone to basically treat it as a medical device. You just need to regulate how the software is being run. And that's a huge thing, because now you can basically start talking about getting FDA clearances and FDA approvals for using your smartphone to use it as a medical device. So I think that they're actually doing the best they can. And I think it's a progress which is going to take, it's going to happen, but it's going to be slow.
Well, and to this point, I mean, it's the same, right? So if you get blood pressure data from a variety of devices and a smartphone that analyzes things, I mean, they've been very, very positive with us in just trying to figure out how are we going to make this work? Because their main concern is safety, right? The FDA's only real job is safety of individuals. It's not efficacy only. I mean, I think efficacy is nice, but that's not really what they're trying to regulate.
Yeah, and I definitely agree. You know, I haven't been involved in the direct FDA conversations that we've had, but my sense is the same, is that, you know, I grew up with a biomedical engineer who was working with the FDA with this like tangible device that they were able to test and sort of confirm, and there's just so much intangible here in terms of it, and I would verify what the gentlemen have offered, that they've been very open in kind of how we're going to do this in the right way. And I think in terms of this tension that we're sort of, experiencing, I think interoperability as a word ends up being sort of the, and then you combine that with safety, and so you end up finding this kind of, the value of interoperability in our health system. Everybody wants that, and so I think that the FDA recognizes that and wants to do what they can to support that happening.
I also think that there is unfair fear of the FDA. As someone who's designing technology for in the medical space, I think the bar they're asking for a simple bar, which is that you have evidence that it actually works and it's safe. And unlike a Gmail server, which you might release an alpha version and it might basically break, in the medical space, you can't really, safety is the most important thing. So I think, and if you want to be designing a product in the medical space, you need to basically make sure that your thing is actually safe. So I don't think that they're basically making the bar to be any higher than what's already required in this particular space.
That's a good question.
So you guys spoke a lot about the consumer, the patient. And I'm wondering, when I speak to my specialist friends, their biggest concern is that they're spending 50% of their time on useless stuff, which is non-patient facing. So how do you win the trust of the providers in order to kind of make this an effective transformation that you're all trying to drive towards?
Yeah, I mean, in our case, we sit, like I said, between the provider and the patient. We're trying to navigate this complex relationship where we're helpful but not an extra cook in the kitchen. And we're not the doctor in this specific case. They're the doctor still making the decisions, or the healthcare, managing entity. And so for us, it's been showing them the data about their patients in kind of an aggregate way, and then showing them how much better they improve their patient population by using Sentinel. So if they have 100 patients on Sentinel, as any given provider might be able to do, and their patients all of a sudden have reduction in blood pressure, that's pretty easy to watch because it's just a bar graph that goes down. We just present that to them on a daily basis or weekly basis, and then every month or so, we're going to start giving them a sense of where they stand relative to their peers, and that may be kind of exciting for them because every doctor thinks they're the best, and so we're just all used to thinking we're better than average, and clearly that's not the case. And so I think it's important to not waste their time, to your point, but show them that they're doing something meaningful. Because if, when I sit in an Epic or Cerner kind of situation, I'm just typing and pressing things and making sure that I check something, basically incurring liability that I don't even know I'm incurring to make sure that I signed off on something, it's kind of difficult, right? And that's, I think, the stress that people, especially the generation like my dad, who's a doctor, kind of face. So they just feel like all of a sudden it's just harder to be caring.
And I feel like you are like a plant to the
Yeah.
whole reason
Yeah,
why
it's like 98.6.
you know, took a job at 98.6, and is to change the experience of the clinicians. You know, the quadruple aim, you know, the triple aim evolved to the quadruple aim to include the the clinical team experience. And, you know, I'm not as, well, maybe I'm as idealistic as Nirav, but I would say that, you know, it's great to be able to have physicians and providers of care feel motivated about this sort of, you know, improvement of care. But the doctors that I've worked with in primary care, it's like, let me just reduce the number of clicks that I'm making in this EMR because it's, you know, a minute per, and, you know, that adds up to all of the time that I'm not going to have at the end of the day with my family or in my hobby or whatever it is that I love. And that's what it really boils down to, is that these are people. And so the EMR, what the EMR has become for us, is really this data gathering scenario. And you have all these people that participate in this data gathering experience of coming into a brick and mortar appointment and the whole deal. Do we really need all that? Especially when we have all these devices to gather the data for us. Suddenly I don't even need an MA. You know, we do need RNs because they help us with decision making. But, you know, the whole idea of, you know, a physician getting all the data, having it distilled in front of you, and now suddenly I'm saying yes, I'm just making a decision. Like, that's what we're trained to do. And that is, I think, helping clinicians feel
And I think there's a
more
great
confident.
point, because I think where technology can help is making the doctor-patient relationship more human. Because when you go to the hospital, if the doctor has to type most of the time, they're not really looking into your eyes and talking to you. But if you can get technology to basically do a lot of this background work, which the physician today has to do, they can spend more time with the patient. So I don't think of technology as trying to basically get rid of doctors or trying to it's basically trying to make their job more personal, which is why I presume a lot of physicians got into this space in the first place, which is basically to interact and care for the patients.
Well, thank you, Amanda, Shyam, Nirav, for joining us today. Thanks to our sponsor, Regents, for putting together the whole health stage. I believe is it lunch now?